Well, welcome everyone. Thank you so much for joining us for our Child Safety Learning Collaborative. Together, we're stronger. We're so excited to have so many of you here today. Please feel free to keep introducing yourselves and keep the chat going. We definitely want you to be interacting with us through the whole time that we're together. And we can go to the next slide. I'm one of your moderators today. My name is Claire Grace Jones, and we also have Jenny and Lauren helping us move through our time together this afternoon. Just wanted to make a note for all of you that this project is supported by the Health Resources and Services Administration, which we all more familiarly, that is not a word, know as HRSA. And so just wanted to give everyone a minute here to take a look at our funding statement, and then we can go to the next slide. A few technical tips. I think in the last few years, a lot of us have spent a lot of time on Zoom, but definitely want everyone to feel really comfortable so that you're able to ask questions and interact. We just want to let you know that if you have any audio issues, there is if you click the little caret at the bottom, you can switch your audio to join by phone. Everyone is brought in muted, but we do want you to be able to be really interactive throughout the chat. We actually are not using the Q&A for this webinar after all, because we really wanted to give the opportunity for everyone to ask lots of questions, to see what questions each other were answering. If you have a thought or a resource that you want to share, we want you to be able to pop that in there. And so the chat will be open and hopefully really active throughout our whole time together. Just a reminder that this session is being recorded and that you can also click that more little 3-dot icon to enable the captions if that is something that will be helpful for you. And I think we can go to the next slide. We are so excited that we are going to spend the majority of our time today hearing from states the work that they're doing. We're really excited to be able to have them share with you, and then to spend the rest of the time having discussion and questions, and just really excited about this opportunity that we have together today. I'd like to take just a minute to introduce each of our presenters because they have so much expertise and background that they bring to their work and that they're going to share with us today. And so we have Colleen Nelson, who's the Infant Safe Sleep Program Coordinator at the Michigan Department of Health and Human Services. She previously worked in child care licensing and also in child welfare. She received a Bachelor of Science degree in Family Community Services from Michigan State University and a Master of Social Work degree from the University of Michigan. Colleen's been involved in infant safe sleep work since early in her career when she was a CPS worker and had to investigate infant deaths. Since that time, she has always done work related to infant safe sleep in some capacity, from participating on infant safe sleep advisory committees to working on trainings. LaDonna Merville serves as the communication specialist and grant coordinator for the Tennessee Department of Health Suicide Prevention Program. She's a public relations professional with extensive experience in strategic communications planning, writing, media relations, community relations, government relations, economic development, healthcare communications, and public relations counseling. Prior to joining the Tennessee Department of Public Health, Ms. Merville was responsible for coordinating membership communications, media relations, and other public relations and communications for the Hospital Alliance of Tennessee, the organization that represents not-for-profit hospitals on Tennessee's Capitol Hill. Her talents have been recognized by the Nashville chapter of the Public Relations Society of America through the Hercules Award, an annual award in recognition of outstanding career achievement in public relations. She and her husband, Ron, reside in Nashville with their daughter. And we also have Terry Love, who has a Master of Social Work. He's a community leader with over 25 years in community-based prevention. He's worked in multiple settings to develop leaders and motivate stakeholders to facilitate population-level change in school, community, and statewide settings. Using data, evidence-based methods, and policy, he's assisted communities with identifying and mitigating the root causes of behavioral health problems and implementing population-level change strategies. He enjoys the process of influencing change and is eager to share his knowledge with others. As a native Arkansan, Terry has adopted Middle Tennessee as his home, where he works as the Injury Prevention Director for the Tennessee Department of Health with the goal of reducing multiple injuries excuse me, and issues including but not limited to motor vehicle crashes, traumatic brain injury, suicide and adverse childhood events, ACEs, ACEs. Terry enjoys exploring Tennessee with his wife, Tammy, and daughter, Anna Marie. And just a quick glance at our agenda for today, we're going to have a brief overview from Jenny of the Child Safety Learning Collaborative, and then we'll move into our examples of quality improvement and injury prevention. And then we're really excited to talk to you about opportunities for what comes next. And now I'm going to hand it over to Jenny.
Thank you so much, Claire Grace. Welcome, everybody. I just want to start by providing a brief overview. Established through funding from HRSA's Maternal and Child Health Bureau in 1990, the Children's Safety Network has been MCHB's primary vehicle for providing technical assistance to Title V agencies on injury and violence prevention for youth ages 0 to 19. Today, we'd like to share some highlights from one facet of this comprehensive work, the Child Safety Learning Collaborative. Learning collaboratives are commonly described as a systemic approach to process improvement, where participants will share their experiences to accelerate learning and broaden implementation of best practices. As the primary driver for CSN's mission to support Title V agencies, the Child Safety Learning Collaborative is an unprecedented opportunity for states and jurisdictions to collaborate with the aim to advance evidence-based policies, programs, and practices at both the state and local levels to reduce fatal and serious injuries among infants, children, and adolescents age 0 to 19. The CSLC, as we commonly call the collaborative, was launched in November of 2018 and consisted of 3 cohorts over a 5-year period. Each cohort lasted approximately 18 months. We are just now concluding that final 3rd cohort. Teams in the CSLC have been working on select injury topic areas that were identified by HRSA, Children's Safety Network, and the Children's Safety Now National Alliance as areas with the highest need and that are ripe for improvement. The design of the CSLC has been for states to create their own strategy teams that then address each of the injury topics they are working on. And then the Learning Collaborative at CSN has convened those state strategy teams into topic teams where we use quality improvement methods to build on shared aims, evidence-based approaches, data analysis, and targeted technical assistance to accelerate the implementation and spread of effective strategies. Throughout the CSLC, teams have access to tools and support that are available only through the CSLC member-only web portal, as well as the general CSN activities such as state technical assistant webinars and other published resources that CSN has throughout the year. Our goal within the CSLC is to help states and jurisdictions employ the public health approach, close the gap between research and practice, and support evidence-based practices to reduce child injury and violence while demonstrating significant change over the 5-year period. To achieve this goal, we utilize the CSN framework for quality improvement and innovation in child safety. A link to the free publication that you can download from the CSN website has now been posted in the chat. The CSN framework focuses on building public will and state jurisdiction capacity in key areas essential to achieving sustainable and scalable child safety results. To build this approach, CSN's framework draws on elements from several different models, including the CDC social ecological model, the Foundation Strategy Group's collective impact approach, the Institute for Healthcare Improvement Breakthrough Series, and the Associates in Process Improvements Model for Improvement. The cornerstones of our framework are identification and use of data-driven, evidence-based, and evidence-informed strategies and programs to enhance child safety expertise, increased effectiveness of management and leadership, and systems improvement through ongoing commitment to shared learning and principles drawn from advances in improvement and implementation sciences. Health equity is embedded throughout the framework. One approach that we leverage within the CSN is the model for improvement. And this is a tool for accelerating organizational improvement. The model centers on clarifying the aim, or what are you trying to accomplish, and then determining the changes that you think will result in an improvement and what data you will need to collect and analyze in order to know that the change actually is an improvement and not just a change in circumstances. The Plan, Do, Study Act cycle serves as a primary tool to conduct small tests to effectively try new child safety approaches and interventions throughout the system and adapt them to ensure that they are working before then moving on to implementing them system-wide. And this is the key quality improvement approach that we utilize in the CSLC. Another facet of the CSLC is the rich and individualized support provided to the strategy teams. For example, teams have been able to draw from the change packages and the strategies provided to identify new options, organize their strategic approach into manageable components using tools such as 90-day aims and PDSA cycles, and then leverage new and existing partnerships to help pivot their work and as well as scale it up and spread. Additionally, over the course of the CSLC, CSN integrated feedback and experience from the participating teams and created new tools that were designed specifically to help states align their CSLC work with existing work under their Title V state action plans, clarify data sources, and clarify partner roles and relationships to other work within their state action plan. An example of this is the Health Equity Planner tool that we released in 2021, which is designed to support assessing and incorporating health equity at the programmatic and organizational levels. A link to this resource is also being posted and you can access it for free on our website. We prioritize time in our topic calls where we're convening the state strategy teams and in our learning sessions where we convene the entire CSLC in order to provide ample opportunity for teams to share their various challenges as well as lessons learned and successes. And this you will be getting a glimpse of today in our presentations. Teams are also able to request individual technical assistance at any time. Over the 5 years of the CSLC, we've engaged a total of 24 states. States then form strategy teams to address one or more topic areas, with some states having more than one strategy team. Thus, we've had a total of 36 teams over the 5 years. During the CSLC, states were encouraged to continue on into successive cohorts. We have retained a total of 56% of our states and jurisdictions for 2 or more cohorts, and 33% of the states actually stayed in for all 3 cohorts, some of whom you'll be hearing from today. While individual states have been tracking their own progress and results and using those to drive their work, CSN has also been looking at the impact of the CSLC using the framework outputs on improved child safety systems and improved workforce development in order to create improvements in child safety. We published the results of cohort 1 from the CSLC in the peer-reviewed journal Injury Prevention and hope to do further analysis of cohort 2 and cohort 3 data now that the CSLC has completed. We are sharing a link to the manuscript on cohort 1 in the chat for your access. Before handing today's event over to our CSLC teams, I'd like to leave you with a few statements that were shared by cohort 2 members at this same type of webinar that we did a year ago when we asked them what the value of the CSLC has been for them. Universally, all participants agreed that the collaborative environment, peer learning, and targeted technical assistance has enabled them to weather the challenges that were further exacerbated, particularly by the pandemic, which really did consume the majority of our child safety learning collaborative experience. And yet they were still able to achieve progress because of the support and the guidance provided by their peers as well as by CSN. With that, I'm going to pass the baton now to Colleen Nelson from Michigan to share the work of their sudden unexpected infant death prevention team during cohort 3. SUID prevention is much easier to say. All right, Colleen, I'll hand it over to you.
Thank you. You can go to the next slide, please. So I'll be talking about the work that we did in Michigan as part of cohort 3, and we focused on sudden unexpected infant death prevention, as she stated, or SUID prevention. Next slide. So really my program, I work in the Infant Safe Sleep program, and the vision of our work there is that families understand the Infant Safe Sleep guidelines and are supported in implementing those guidelines. And for all of you who may not be familiar with those, they can be summed up basically with this graphic, which is from the Detroit Health Department, one of our local health departments that worked in this area, and it's used with permission. But babies should sleep alone on their back in a crib, bassinet, or pack and play. And then we would ideally have them be in a smoke-free and nicotine-free environment. Next slide. And then that, vision really leads us to our larger vision, which is in our Mother Infant Health and Equity Improvement Plan. And this is a plan that has really guided our work in the area of maternal and infant health. And that vision is 0 preventable deaths and 0 health disparities. And we recognize that that's a very lofty goal, but really, really want to say what our ultimate aim is, and so that's where we landed on. We would really like to see 0 of those preventable deaths and 0 disparities. Next slide. So why are these our visions? So in Michigan, a baby dies every 2 to 3 days due to sleep-related causes, and a sleep-related infant death are those where the sleep environment likely contributed, and that could be due to pillows, blankets, or other items in baby sleep environment, or due to a co-sleeping type situations. And we do know that most of these deaths are preventable. As an example, if all sleep-related deaths were prevented in 2019, Michigan's infant mortality rate would have decreased by 20%, or saving 149 babies. And then, so to give it a little closer look at the data, from 2010 to 2019, 1,436 Michigan babies died from sleep-related causes. And then remember how I said we want 0 health disparities. We have that because disparities do exist in these deaths. Black infants are 3.8 times more likely to die due to sleep-related causes than white infants. Preterm infants are 2.5 times more likely to die than full-term infants. And then low birth weight infants are 2.9 times more likely to die than infants that weren't born with a low birth weight. Next slide. And we know, in this work that there are challenges to practicing safe sleep for families. Families don't always receive the education on the safe sleep guidelines. Now, I feel like in Michigan, we do a pretty good job of this, and, most families we encounter do have some basic knowledge of the guidelines, but they don't always, sometimes there's some disconnect between understanding the guidelines or having heard them and then how you implement them. And then kind of on top of that, they may receive incorrect or conflicting information. And this can be a difficult one to address. We know that others in their life, grandparents, aunts, or even medical professionals may tell them incorrect information. And social media can also be another source of incorrect information. And then another, challenge we see is that families don't always have a safe sleep space for their infant. They may not, and then, if they have a space, they may not have space to put it. This is one that's come up a little bit more recently where when families are living in an overcrowded situation, they may not even have room for a pack and play or a safe sleep space. So, to kind of figure that piece out can be a challenge. And then the final challenge, I can't really overstate this one, but it's hard to practice safe sleep. Babies are hard. And when someone practices safe sleep, it actually makes baby sleep less deeply. It makes baby wake up more often. And these are all good things and they're protective, but it also makes it more challenging for families to follow the guidelines, especially when they're facing other stressors in their lives or just, having to go back to work and, getting lack of sleep, all those things. So, kind of wanted to share these challenges to kind of frame the next piece of the work. So next slide. So through our work with the Children's Safety Network Learning Collaborative, we use their Sudden Unexpected Infant Death Prevention Change Package to select a strategy. The strategy we selected was to train first responders, and we specifically looked at firefighters and emergency medical services or EMS providers in safe sleep to enable them to identify and eliminate sleep hazards while on emergency calls. We chose this group for several reasons. First, fire departments and EMS providers are in the unique position of being present in citizens' living spaces. They are kind of the eyes and ears of the community. They are welcomed into families' home, and they are trusted to help. So they're really in the unique position to be talking to families about safe sleep. And in this work, we kind of look at every call can be an opportunity to recognize evidence of infant in a home and check for a safe sleep environment, not just those typical pediatric calls. Also, there's a huge number of providers we could reach. In Michigan, there's 800 licensed EMS agencies, and there's almost 30,000 EMS providers in the state. So, think that's a big group of people that we could reach with the safe sleep education to, and then turn provide that to families. And next slide. And before I really talk about what we did in this chain or in this strategy, I have to acknowledge my colleague, Dr. Sam Mishra. She's the EMS for Children coordinator within our department, but in the Bureau of Emergency Preparedness, EMS and Systems of Care. If it wasn't for her, we really wouldn't have been able to implement the program as robustly as we did. So beginning in January of 2022, we worked on developing a process for EMS providers and fire departments to become Safe Sleep certified. Dr. Mishra had a few providers that were already pretty engaged in safe sleep work, and we relied on them to help us test pieces of the program and get their input on how things might work. And so really we developed the program with I think 3 tenets of things. So really we wanted to make sure that the providers had education on safe sleep and were aware of the safe sleep guidelines and really how they can help families. Another piece of it is to make sure that those EMS providers are connected with their local safe sleep resources and just general resources for families. So part of the program is we connect them with those, so be it the local health department or other community-based agency that does safe sleep work. And then the third piece is making sure that they have access to pack and plays or safe sleep environment if that's determined to be a need. And that access can be through their local contact or through Dr. Mishra's EMS program, where they have some funding to purchase pack and plays for families in need. So beginning in January of I already said that. So we worked early from January to late to July to implement the pieces of the program. And then we were able to launch the program in July of 2022. And so since that time, we've had at least 660 or a little more providers trained on safe sleep. And then 12 EMS agencies and fire departments have reached the certification level where they've, met all the requirements and have become certified. And then we have 9 other agencies and departments that are enrolled and are working to become certified. And then through that work, we've, reached at least 41 infants. And I would say, I think this number is like a low count. Part of the program is when the EMS agencies and fire departments have encounters with families that they're submitting a really brief survey, just kind of documenting their encounters. And this is one piece where we're working on how to ensure that this happens, because we know that there's been difficulty in this piece. So I say at least because I know, with that many providers trained on safe sleep and they're encountering families all the time, we know that there's been more than 41 infants and families reached with the safe sleep message. Next slide. And then this really is where we have certified providers. It might be hard to see, but different counties within the state that have certified agencies. I would highlight the county over on the left side. This is Kent County, where the city of Grand Rapids is. And we have 4 provider or EMS agencies and fire departments that are certified in that county. And part of that was this Kent County Health Department really was invested in this project, and they started their own cohort. And so they kind of manage a cohort of helping EMS agencies and fire departments to get certified, and they do like a quarterly meeting with them, and they provide a lot of hands-on support. So, and they're working to, get more certified in their agency. And as we fine-tune the program, we're hoping to, implement cohorts in some of our other larger counties to do a similar thing, because that work has really made it a lot easier for the agencies to come on board and be supportive and, have those connections with their local resources in the county. And then next slide. And then really our next step is to continue to recruit and certify EMS agencies and fire departments, and continue to support those that have become certified and that are, coming on board to become certified. We have implemented a quarterly call with all our certified agencies, just as a time to share, what's happening with them out in the communities, and share any updates or, new information with them regarding the program. And then I think as needed, we'll continue to make adjustments to the program and do those, little cycles of improvement to, ensure that that the program is easy to implement, and that providers have what they need to educate and support families.
Great. Now we'll hear from LaDonna Merville. Thank you, Colleen.
Thank you. You can go to the next slide, please. Good afternoon. My name is LaDonna Merville, and I serve as a Communications Specialist Grant Coordinator for the Tennessee Department of Health Suicide Prevention Program. I want to thank you for giving us the opportunity to share our work to address suicide and self-harm in our youth population. Next. First, let's start with an overview of the state and how we structure our work. The Department of Health Suicide Prevention Program uses grant funding to contract with the Tennessee Suicide Prevention Network to expand and support multiple suicide prevention activities. TSPN is a statewide organization that offers suicide prevention training, support, and resources within all 95 counties of Tennessee. TSPN works with us to strengthen the public health approach to suicide prevention. TSPN also helps manage the implementation of the Sources of Strength program by recruiting youth and trusted adults to implement SOS in schools and community-based organizations. Lastly, TSPN is also working with K-12 schools and higher education institutions to update suicide prevention, intervention, and postvention policies and plans. Next. Here's a quick overview of youth suicide in Tennessee. Suicide is the 3rd leading cause of death for young people aged 10 to 24. There were 32 deaths by suicide in 2019 in children under the age of 18. That's a rate of 2.1 suicides per 100,000 population. Next. Here's a few suicide-related details from the youth suicide in Tennessee, about youth suicide in Tennessee from the 2019 Youth Risk Behavior Survey. I know there's been a more recent survey, but that came out after I'd completed this slide. So anyway, in Tennessee, 19.2% of high school aged children seriously considered attempting suicide. 15.4% of high school aged children planned how they would attempt suicide. 8.3% of high school aged children attempted suicide, and 3.9% of high school aged children that had a suicide attempt resulted in an injury that needed treatment. So on the average, every year in Tennessee, 21,000 or more young persons are called the suicide crisis hotline. Next, please. The Department of Health's chosen strategy measure for this cohort was to increase the number of QPR gatekeeper trainings provided to youth impactors. This strategy was selected because the Department of Health was already conducting QPR training and supporting TSPN as they provided training across the state. The strategy also aligned with suicide prevention activities focused on youth that included providing training opportunities for mental health and suicide prevention for students, teachers, school support staff, and other adults that interact with youth and children, implementing peer-to-peer programs such as Sources of Strength and Hope Squads in middle schools and high schools, and incorporating a protocol for responding to Essence alerts into school suicide prevention response plans. Next, please. Through our contract with TSPN, we track the total number of gatekeeper trainings. The number of gatekeeper trainings, and this is QPR and assist, increased between 2020 and 2021, but declined in 2022. We believe this may be due to some staffing and leadership changes in our contracted agency and the loss of some of our QPR instructors across the state. And I think because of COVID also, we weren't able to do as many train the trainer sessions to replace those that we lost. Next, please. We also track through TSPN the number of youth impactors that received gatekeeper training for suicide prevention. That number has steadily increased from 2020 to 2022. One reason could be that the availability because the availability of virtual trainings that can be accessed from any location. Next. In order to inform our suicide prevention efforts, we use syndromic surveillance to track suicide-related behavior in Tennessee. Essence is the electronic surveillance systems for early notification of community-based epidemics. It is available in the National Syndromic Surveillance Program BioSense platform, that's a lot of words there, to improve data quality, efficiency, and usefulness. Syndromic surveillance is real-time surveillance of people dealing with suicidal behavior. It provides public health officials with a timely system for detecting, understanding, and monitoring health events, and it allows for the tracking of symptoms of patients in emergency departments before a diagnosis is confirmed. Therefore, it allows public health professionals to detect unusual levels of illness to determine whether a response is warranted. Next. We use Essence to get several different types of data. This includes trends in suicidal behavior and risk factors, alerts for increases in suicide-related ER visits. We also feel like it gives us some timely provisional ED data, and it also provides some assurance that suicidal behavior has not occurred. Next. We use Essence to monitor weekly trends in suicidal behavior and identify counties across the state seeing increased incidents of persons reporting to an emergency department for suicide-related behavior. Currently, 100% of Tennessee hospitals with emergency departments report into the system. Each week, our staff reviews reports on how many people visited a local emergency department for suicidal ideation, injuries related to intentional self-harm, or suicide attempts. Next. There are some specific restrictions regarding what we can provide and the data that is not available due to data release guidelines. We do not provide any information with counts of less than 11 or specific hospitals in accordance with our data release guidelines. Surveillance is conducted across the lifespan to include all age groups, which include 5 through 17, 18 through 24, 25 through 44, 45 through 64, and 65 and older. The next steps for our surveillance includes increasing risk factor identification, providing monthly reports and mapping, and quarterly data briefs. Next, please. There are 3 types of risk factors identified in Essence. First of all, the individual risk factors, such as identifying as a gay, transgender, or transgender individual, anyone who may have a major depressive disorder, anxiety disorder, a previous suicide attempt, prescription, non-prescription drug use, or misuse, recurring mental health issues, criminal problems, gender dysphoria, if I could say it right, or having hallucinations and hearing voices. We also track relationship risk factors, such as the death of a family member, the death of a family member's suicide, not being accepted by a family due to LGBTQ status, or threats from harm from the individual family members. And finally, we look at community risk factors, which include problems at school, any disaster-related problems, and anxiety, and particularly during the time of COVID and lockdowns, we looked at that as a risk factor as well. Next. If a certain county reports an above average number of suicide-related emergency department visits for a set age group, an Essence Alert Bulletin is triggered for that county and age group. The weekly alert data bulletin notifies community partners about the increase in suicide-related behavior in their area, any trends and demographics that were noticed, and the risk factors noted during reported visits. In addition, the response also refers individuals to prevention resources, support, guidelines, and trainings. And individuals from across the state are able to sign up to receive Essence alerts either for their individual county, or for their region, or for the entire state of Tennessee. Next, please. We feel like it's very important to ensure that the data we collect helps us improve our suicide prevention efforts. We work with TSPN and other partners to implement a comprehensive rapid prevention response plan, which incorporates community response samples for each specific age group. The response plan helps guide community members on actions they can take after an Essence alert is received. As an example, in 2022, we had more than 225 individuals who subscribed to receive Essence alerts. After the data was distributed, or the alerts were distributed, we tracked information that showed there were 13 prevention activities reaching 42 individuals, and one suicide prevention awareness event that reached 5,000 individuals. We also know that cross-collaboration occurs between stakeholders, and we are working with TSPN to improve response plans across the lifespan. Next. We conducted a recent needs assessment recently to identify any gaps in our programs and any opportunities to improve. As it relates to gaps, we identified that obtaining and paying for mental health care was an area of need. However, we also identified that there were opportunities to improve increasing awareness of suicide and the availability of mental health resources to access affordable care, particularly in rural areas. Next, please. One of the ways we've responded to raising awareness of suicide prevention and mental health resources is through the publishing of a statewide directory. This mental health and suicide prevention resource directory provides basic information on what to look for, when to act, and who to contact for the various situations that may factor into a mental health emergency or suicidal crisis. It also offers resources and services available across the state for high-risk populations and organizations and coalitions working to prevent suicide in Tennessee. Next. We also recently published our annual report for 2021-2022 to provide data on deaths, suicide attempts, ideation, and risk factors. The report also highlights our syndromic surveillance efforts, communications activities, and our information about our suicide prevention task force. It includes prevention recommendations based on the input of our task force and other statewide partners. Next. Our future plans include using data from the Tennessee Violent Death Reporting System to fill in the gaps around circumstances and risk factors related to suicide. We've also received some additional funding to enhance education about and awareness of our Essence program. Some of the plans for this funding include educating hospital partners and emergency department staff on the importance of reporting into Essence in a timely manner and understanding the work that is being done with the information put into Essence to prevent suicide attempts and death. We're also working to educate the public and organizations that serve the public about Essence, the alert system, and what communities can do after an alert has been received within the areas in which they work and live. Finally, also, we've recruited some new or continue to recruit new Essence Alert subscribers from rural areas who work in populations that address the risk factors that we are seeing in our Essence Alerts. We are working to fund rural county health councils in high-risk areas to develop and implement a response to our weekly Essence Alerts, and also working with organizations that serve our selected vulnerable populations to improve the response to Essence Alerts within rural communities, and coordinating prevention efforts across the state that in response to our Essence Alerts. Finally, we're conducting a study to determine ways to improve our syndromic surveillance efforts. Next. Thanks for your time today. Please let us know if you have any questions.
Well, thank you so much. Thanks, LaDonna, and thanks, Colleen, for describing your work. I think it was I really appreciate hearing such detail about what you've been doing. And I know I have a bunch of questions, but I did want to open it up first to any questions that have come from anybody. So if you have any questions, please feel free to type them into the chat. I think I'm going to start with just a general question, actually, for both of you to think about what's the biggest challenge you've encountered over the past few years as you've been trying to do this work. And then if you can think of a challenge, what kind of strategies or innovations have you used to address that? So I don't know who might want to go first there. I didn't give you any time to think about it, really. Do I get Colleen, would you like to start?
Yeah, I can go first. One of the challenges, I think, for our certification program really is identifying the local resources that the EMS agencies and fire departments can connect with, because we really see this when they provide the education and opportunity to, if the family seems like there's other needs that they might have, that they have a local connection and can refer the family to them. So specifically related to safe sleep spaces, like a pack and play or something like that, not all the local agencies, have that. So, and it's really depending on the area of the state. Some counties are really well resourced, and others might not even have a local agency that is doing safe sleep work at all. So that's just been a challenge, because we want to, make sure that, if we're sending the EMS providers out there, with safe sleep education, that they have local connections. And then I think, just as, we've tried to overcome that challenge, is, we've tried to, really just working locally to ensure that there is at least somebody, even if it's just a local health department, to get other supports for the family, that there's a contact. And then through the EMS for Children program, Dr. Mishra has been able to, get some other additional funding to kind of supplement and provide at least pack and plays when needed, if we don't have other local connections.
Okay, well, thank you for sharing that. How about LaDonna? Do you have a main challenge that you've experienced, and how have you worked to overcome it?
Well, I may ask for Terry to jump in with this a little bit. I think one of the challenges we've identified is we have a contract with the agency I mentioned, the TSPN, and they've had some leadership and staff changes, significant leadership and staff changes over the past year. So it's been some of a challenge to keep up with what they're doing and make sure they're staying on track with what their deliverables are. So that's been a challenge. So we've really been working with them and their regional offices, regional directors, to try to make sure that they're keeping good records about their trainings, who's attending, when the trainings happened, that kind of information and data, because that's really, helps us to determine, if we are getting raising awareness and developing more people who are aware of how to intervene if there is someone they know that is experiencing a suicidal crisis.
Well, Donna stole my thunder. I think one of the biggest challenges for us is participating in the collaborative. Turn Brittany into a subject matter expert. And we lost her. Our director got hired away from us. I mean, not just that. I mean, but Brittany has she's really worked hard, and because of the training she received, partly here and partly through the CDC in this work, other agencies lured her away. So that's one of our challenges, that we lost our director. And then LaDonna mentioned that our partners also, there's a lot of turnover in the field right now. People are retiring, people are moving job to job. So this constantly changing landscape of providers and then bringing people up to speed. And LaDonna doesn't get enough credit, but she stepped in and done a wonderful job with helping us with our efforts, and evident today in her broad knowledge and specific knowledge of what we're doing and how we're getting it done. So that's one challenge. I think the other challenges around Essence, and I saw some of the questions about Essence, getting all of our emergency departments to participate, and then staying on track of that data, identifying risks and protective factors. That takes a full-time position, which that position became vacant and we just filled it. So those are a couple of the challenges. Other than that, I think we've been doing pretty well.
Sounds like you've been doing really well. Sounds like, despite the challenges, especially around staffing, which seems to be a challenge everywhere. There was one other question, actually, I think it's for LaDonna and Terry. Somebody asked about how did you overcome any HIPAA disclosure issues with the rapid response system? For example, does the family provide you with approvals to release the information? Oh, actually, this was a safe sleep question, wasn't it? I apologize. I think so. Anyway, maybe this would be for either of you. How did you overcome HIPAA disclosure issues with the rapid response system?
I think the question is for safe sleep, infant sleep work, but I can say for us, we're not releasing information in a way that it violates HIPAA policies or Tennessee Department of Health policies. So all the data is de-identified. The algorithm of the Essence alert is really just a number of alerts, and did that number of alerts in this particular age group exceed the algorithm for the previous month? It's kind of complicated. We need our epi to explain it, but essentially, it's not no personal identifiable information is released through the Essence alert. That's our end of things.
Okay, so you're able to do the alert without actually identifying any individuals. Okay. Thank you. I actually had please people keep oh, there's another couple more questions here. Oh, I see what Nick said is that the question was for Tennessee, but that your approach might also apply to safe sleep programs. So thanks for that question. I have a question here for Colleen. What safe sleep certification programs do you use to train first responders?
For the training that they do on safe sleep, we actually have a number of different options that they can use. We've had a little bit of infrastructure in Michigan for training EMS providers. A number of years ago, we had the DOSE program, the direct on-scene site education, I believe, and that's from a group out of Florida. So some of our EMS agencies had previously taken that training. And then we also, through like our EMS side of things, there was a safe sleep course that many EMS providers had already taken. So that's available, like an online training. So when we implemented the program, we didn't want people to have to start over and take a new training if they've, already done the training. So we gave like a grace period if they had taken one of those previous approved options. that would be included. And then we have also, we created like a peer training where, like, if the EMS agency wants to do a live training with their staff, we have like a PowerPoint template that they can use, and then it's like they modify it for like adding in some data for their local community. And then we also, through that partnership that we set up between the EMS agencies and their local Safe Sleep resources, we also allow their local Safe Sleep contact to come in and do a training as well. So they really can pick any of those options for their training for staff.
Well, by having options, it seems like that actually makes it easier for them because they don't have only one model to follow. I guess that was actually a question that came up in our list here about whether there have been any challenges or barriers in building these partnerships with EMS or with first responders. Like, have they been open to this partnership? Were there any that were harder to convince? And how have you overcome any kind of issues there?
I think we haven't rolled out the program like widely yet because we've had so much interest just with providers that already were engaged with Dr. Mishra's office. A lot of them are pediatric champions, so they've already have an interest in this area. So for the ones that we've engaged, they've all been willing to do the process and the training. And, like I said, initially we, worked with some of those key people early on to get their input because we wanted to make it easiest, like an easy program for them to implement. So that wouldn't be an issue with getting programs on board. I think the piece of it though is once the first responders are trained, really them then talking with families and taking that next step. I think this can be a scary topic to bring up, and you don't know if you're opening a can of worms with a family. So I think there may be some hesitation and need to do additional supports like within the EMS agencies to make sure that their providers are comfortable having that conversation, and then like following up with the family if they need additional supports.
That's a really good point. I mean, it just makes me think that any kind of strategy or change that you want to make, there's sort of, I wouldn't say unintended consequences, but sort of unexpected barriers that you have to really think about. And that's a big one. And that's something that you need to just figure out how to make the room for them to overcome those challenges and to talk about the difficulties of talking to families about a hard subject. I just wanted to take a step back and ask both of you, as long-standing members of the CSLC, how this group has been a part of supporting your work. And I know that, as one of the topic leads, I really enjoy hearing the cross-state collaboration. And I'm wondering what that's looked like for you and how you've been able to benefit from that. And I'll start with Terry and LaDonna for that one.
Sure, I can address that. I guess I've been with the cohorts from the beginning, or pretty close to the beginning, maybe back when it was coin or before then, and I have to admit in the beginning, I was like, wait a minute, why am I joining these meetings, these extra meetings? But what I found is it's really a culture of collaboration and learning and support. I've made friends here. I've made connections in other states, and when we were doing the vehicle crash prevention work, the checkpoints, I mean, we're able to not only spread checkpoints through Tennessee, but also Kentucky and Florida requested the program, and Texas, and so we shared data, we shared the woes of injury prevention, and supported one another through COVID. This was important, I think, as well, for us not to feel so alone and isolated. And it's really, I think it's changed the culture of injury prevention, and it's impacted it certainly to support, again, these regional and state and national, regional and national efforts. I do think it's influenced policy because we discuss policy here. And so, yeah, very, very positive effects for us in Tennessee.
That's really great to hear, and that you sort of answered my other question about why you might why you chose to stay on for additional cohorts. It sounds like you built really good relationships that really supported your work, especially through the pandemic when you really needed those virtual connections. Colleen, I know you haven't been part of CSLC as long, but can you share a little bit about how it's been supportive to your work?
Yeah, we were only just in this last cohort, but I think it's really been helpful in this work because there were some pieces that like the EMS side of things we're doing and that we were trying to do with making sure EMS providers were trained, and it really gave us an avenue to like implement, like it gave us that push to implement the program and fully vet out what the process was and like formalize something that we were already doing. And I think even a piece of the cohort was like doing a monthly report, which seems, it's a task oriented thing, but it was really helpful in like, okay, what are we doing, and keeping us on task and keep us going. So I found that like really helpful in, just kind of moving it forward and keeping our eye on the data and checking like, well, are we having the effect that we want? And then how do we make adjustments if need be?
Great. Thank you. Thanks for sharing. I don't see any more questions. We have about 2 more minutes. I don't see any more questions in the chat, but I did have one more, which is thinking about moving forward. Just quickly, each of you, what's one thing you're excited about sustaining as you move ahead? That something that in your work that you're kind of excited that you're going to be able to keep it going. Just a quick bullet point.
I would just say getting more providers enrolled, and then I think implementing that cohort piece where, for some of those larger counties, like having a group of providers work together to get certified and lean on each other like they did in Kent County. I think implementing that piece is exciting.
That's awesome. Thanks.
I would
That's
just
great.
mirror that, the partnerships. It's us working together. The partnership that we sustain, it's the new partnerships we develop, and working through those to push the needle. I hate to say a catchphrase, really make real change with data to action, right? You can see the data to action and back data. So that's what excites me.
That's awesome. Thank you so much for sharing. I really appreciate it. I'm going to turn it back over to Jenny now.
Thank you so very, very much. It was wonderful to hear from Colleen, LaDonna, and Terry. We so appreciate you sharing your insights and experiences. And a few nuts and bolts before we close up today. I just wanted to share some thoughts on how everyone can maximize the benefit of the Children's Safety Network, regardless of being a member of the CSLC or not. As noted earlier, joining the CSLC does entitle teams to targeted technical assistance and tools that have accelerated their prevention work, but CSN also provides universal technical assistance well beyond the CSLC. We annually respond to over 6,000 requests for individualized assistance. And over the last year, 32 states or jurisdictions did receive individualized technical assistance, and 41 states, including some of the members of the CSLC, participated in our bi-monthly state technical assistance webinars, which are available every other month. Anyone can submit a TA request using the link on our website, and also sign up for a monthly newsletter so that you're sure not to miss out on any new releases or opportunities CSN has. Furthermore, with the conclusion of the 5-year Child Safety Learning Collaborative, we have now released the change packages designed and tested during the collaborative. We've posted this webpage here in the chat, and you'll find our comprehensive change packages, as well as the streamlined versions that were used in the CSLC, focusing specifically on strategies at the organizational level of the socio-ecological model. You heard these referenced in both of our presentations today. We also have some outcome data worksheets for each key injury topic to help you strategically identify how and where to acquire real-time data, which will help to inform and accelerate your work. Additionally, EDC is very pleased to announce that we have just received our notice of award from HRSA to continue implementing the Children's Safety Network for another 5 years. This will include a new learning collaborative, so stay tuned, sign up for the newsletter, and get more details that will be announced over the summer about the launch of another round of the learning collaborative. And if that isn't enough, there's one more CSN webinar this month, exploring the relationship between bullying and substance abuse. This is bound to be an excellent presentation. The registration link has also been posted in the chat. You can find it on the website. And in closing, I just want to share some words of wisdom again from CSLC participants over the years. You'll see that these reflect a lot of what you heard today from our presenters. This webinar has been recorded. All registrants will receive a link to the archived posting on our website. We thank you dearly for joining us and ask that you please be sure to complete the short evaluation that you'll be guided to at the end. Thank you again to our presenters and to the CSN team. Have a great day.